Evan is originally from the University of California, San Diego. I guess those are two different things. Yeah. But he saw the light and he went to Washington University. And before you get upset, it was the good one in St. Louis, not the Huskies. He has an MD, PhD, which I always wanted because I wanted to make people call me Dr. Doctor. So we welcome Dr. Evan Saulino. He has disclosed that he works part-time for the Oregon Health Authority on the primary care patient-centered medical home. So just know that that's the only conflict he has, but otherwise he's conflict-free. So please welcome Evan. Thanks.
So thanks a lot, Kevin. So yeah, I do work part-time for the Oregon Health Authority as a clinical advisor for the Patient-Centered Primary Care Home program up there at the top. The other half of my work is as a family doc at a residency clinic. So and we're trying to do this work, this patient-centered primary care home work. And so it's really interesting to me, and really, actually I feel really lucky to be at this crossroads of being able to see and try and implement this stuff on the ground, try and teach residents about it, and then work with practices and the policy at the state level and practices around the state on actually trying to do this as well. So that seeing that sort of crossroads of all that stuff happening is pretty exciting. So what I'm talking about today is complex care management and care plans, which is the documentation part of the, in the title of my talk, the official title of my talk that Carrie put in the agenda. Essentially, you know, when we're talking about complicated patients, if you all just went to John Salsa's talk, which I thought was great, we have to think about certain types of patients and manage them really differently than that reactive care. We're trying to think about being more proactive and prevent things from happening. Of course, react to things when folks walk in the door or they call up or whatever. But trying to think about how to do that efficiently and effectively, and not just sort of add a lot of work to what we're doing, is really what this talk is about. There's a couple of talks later on in the day that really delve into the care management piece more deeply. Paige Hatcher's given those talks, and she also works with the Health Authority and the Patient-Centered Primary Care Home program. So I'm going to go into that a little bit, but I'm going to spend a lot of the talk really talking about these care plans, which is really a mechanism or a place to hold information and share information and to sort of download all that stuff about these complex patients that you keep in your head, that you know these people and you know somebody with 15 medical problems and 20 medications. When you walk in the room, you can say, hey, looks like you're doing well today, whereas somebody else might walk in and say, wow, you look horrible. But you know the person, and you have all this information in your head, and the care plan is really thinking about, really thought about as a place that you can put that information, that other people can access that information, and that the patient is actually really engaged in. So I'll just start going through the slides. There we go. So you saw these again at John's talk, but the patient-centered primary care home model is defined by these 6 core attributes: access to care, accountability, comprehensive whole person care, continuity, coordination, integration, person-family-centered care. These are really evidence-based pillars of successful primary care. But it's this one right here, specifically the coordination integration, that we're going to talk about today. So, and this is the patient-centered language, the normal person language that describes what coordination and integration is, that the state really used. And we've gotten some recognition around the country really for using this patient-centered language and trying to describe what we do in a way that is understandable. So this is really about helping folks navigate the healthcare system and get the care they need in a safe and timely manner. Each of those 6 core attributes of the primary care home standards, primary care home model has different standards and measures. So the specificity of saying not just we're going to do a great job on care coordination and integration, but how are you actually going to do that? So there's standards and measures for that. This model started in 2010, 2011. And I just wanted to put up here a couple of the measures that actually currently address this. So basically, if you're meeting these things, you get certain points to try and meet this patient-centered primary care home tier. And you could be a tier 1, which is kind of the starting out, tier 2 kind of in the middle, or tier 3 kind of the most robust model of care. So there's one standard here where you assign an individual to care coordination. There's another standard here where you're demonstrating that you actually have a process for identifying folks who need care coordination, and then actually coordinating the care for folks with complex healthcare needs. So that's what's existing today that people have been working on over the last few years. The patient-centered primary care home standards are changing or being updated. There's something called the Standards Advisory Committee, which is a multidisciplinary group of family docs, internal medicine, pediatricians, behavioral health folks, pharmacy, health plans, a whole variety of folks who came together to talk about how to make these. They actually made the initial standards, and a new committee did the updates of the standards to try and make them as evidence-based as possible to reflect the knowledge that we have over the last couple of years of implementation of the problems and the potential, really the benefits of changing some things around. So this is a new standard. Oh, I'm sorry. This is still the old standard with 5F and the new standard. Here we go. Here's the new standard. We lumped those the last couple slides I had. We put those all into essentially one standard, which is this complex care coordination. So this is what you're going to have to meet if you're trying to be a patient-centered primary care home. This is what you'll have to meet starting after October, okay? But basically, again, if you compare the last couple slides to this, it's really just kind of mushing those things together and saying, really all those different standards, those three different standards that we had, those things are all under this heading of complex care coordination. So I just have those up there. They're basically a lot of the same type of language, which are identifying patients who need complex care coordination. You're making sure that you actually have people doing that complex care coordination, and that doesn't mean necessarily the doctor doing that at all. And then you're doing care planning for them. So again, you're thinking about a strategy, not just kind of doing it ad hoc, but actually have a plan. So the Standards Advisory Committee identified these things as just examples of care coordination. No, I want to restart now. Yeah, love it. Let me go back. So coordination of care received outside of the primary care home. So that means like in the hospital, mental health setting, community health settings, and in specialized care settings. Tracking of care and tests, so if you order things, do they actually get done? Does the patient follow through? If results come back, are those communicated to the patient? How well does that happen? Self-management and support and education, which is really critical. We're certainly recognizing that as we know, patients are, we're all essentially ultimately responsible for our own health, and there's a lot of things that we do to affect our own health. But if we don't understand the basics of how to do that, or even understand the issues that affect us, then that's pretty hard to do. And the last part is motivational interviewing and coaching on behavior change. Did you have a question?
Are you up for a question?
Yeah, you can, yeah.
So that second little thing, the first one with the dash after it, we've done some review of our charts, and that one always pops up as not being documented in the chart.
Yeah.
And I have not yet figured out how to have that be part of the medical record and be obvious that it's being done.
Right. So part of that has to do with technology of, we all work with different electronic medical records, and none of them really are built for primary care. They're built for urgent care and hospital care and billing. And so it's hard for folks to find a place to make some of these care coordination pieces work. There are some overlays that people design. People design, a lot of times, they fit things into categories that they think would work in the EHR that they can then pull out, but they may not be the place that was built for that. So it's a struggle. We'll talk a little bit more about that later on. So this is from a paper that looked at a whole variety of studies. I think there are 15 or 20 studies about care coordination. So again, complex care coordination, what the heck does that mean in reality? So they actually looked at that and said, okay, so do we know what that means, and does it actually make a difference? And it turns out, it depends. So it depends on what you mean by complex care coordination, or what sort of level of care. It depends on the types of patients that you have, and really the level of this care coordination that you use. So if you have somebody who's really complicated, has mental health issues, that are not well controlled, many different chronic diseases, and they're just coming out of the hospital, an occasional phone call, or one phone call, actually has no evidence behind it to show that it makes any difference. But if you have a phone call that's followed up by another one, you're doing medication reconciliation, maybe if this person has, again, mental health issues, you're coordinating with other folks in the healthcare system. You're actually having folks potentially, either you or home health or your nurse or whomever, actually potentially go out to the house if the patient's really complicated and has trouble with mobility, things like that. Those actually, if you have somebody who's really complex, potentially a really high cost person, because they utilize a lot of medical services in the hospital, this side of care coordination can really make a difference. This side can make a difference for some people if they're not that complex. So these are sort of domains of care coordination that are important to think about as you're thinking about how do we, again, we can't necessarily do everything for everyone. We don't have those resources. So how do you think about what types of things are we doing and how are we going to target those things to the folks that actually need them? And this just kind of gives you a framework of the spectrum of care management or care coordination. And really, I think the key to making this work in a practice is thinking about essentially risk stratifying your patients, thinking about who are the highest risk people. And again, a lot of us have them in your heads. You could list your top 20 high risk people probably right now on a piece of paper, right? You could just list their names because you know them. Maybe 10 or 15 or something like that. But you can do that. So those really complex people are in and out of the hospital, in and out of the ER. You never know exactly what's going on with them. You have just a lot of trouble getting your hands around them, and they have a complex social situation and things like that make them very high risk. And you know that. So those folks, you can just, if you can actually write those names down and have a list of those folks, you can pull them through your EHR with diagnoses. That helps some, but it's really important to not just use diagnoses to pull these high-risk folks, but to actually, again, use your brain and think about, okay, what's their social situation? It's usually kind of the biggest confounding factor for folks to make up that list. So you can actually use a combination of those things and say, these are really high-risk people. These are folks, when you risk stratify people, you think these are really complicated people that we need to put a lot of resources at. So we're actually going to target our efforts, that care coordination at them, and we're going to make that really robust because they need a lot of help. We're going to wrap that care around them in every way we can. Then there's folks who are basically, they diabetic who's pretty well controlled, but they have renal disease and their hemoglobin A1C is like 7.5 or 8, and they're not going in and out of the hospital, but they're not, you can see the trend and you know where they're heading, but they're not too bad off. Those folks are a different level, and you don't need to surround them with all types of care, but you do need to help them, right? So you can maybe provide them with some education, frequent touches on how your sugar's doing, how your blood pressure's doing, you're monitoring home blood pressures, that sort of thing. So some resources towards them, but you're not throwing everything you have at them because they're not really high risk. You want to prevent them from actually getting to that highest risk level. And there's those folks with kind of in the middle with well-controlled diabetes and hypertension, well-controlled asthma. They're taking their meds. They do have some chronic health issues that could potentially worsen and have exacerbations. So you may be talking to them about what do you do if you run into trouble? Your asthma gets worse. Do you have an asthma, a plan for that, an action plan for that, that sort of thing. But you're not, again, necessarily having to touch them frequently to check on their sugars or their symptoms and things like that. They're pretty well controlled. Then there's those folks who are healthy. They come see you once a year, once every 3 years or whatever. Sometimes they come in for a cold, but basically you don't see them. Those folks are certainly need the least help, but you still need to be tracking. That's where electronic systems are really helpful, right? Oh, you're due for your PAP or you're due for your mammogram. Come in for that kind of thing. You're due for your vaccines. That doesn't take a lot of brain work. Ideally, electronic ability can help us with that if you have the EHR. If not, you still got to be tracking those folks in some way, and again, getting their recommended preventive care. But that's really standard and pretty rote, right? And that's not necessarily something that, again, we need to, as physicians, be using our brains to really figure out. We can definitely have, and Rick was talking about, he sort of said he has his MA as in charge of preventive care. Because again, really standard. If you think about, this is the preventive care we want to give to everybody. It's age dependent and gender dependent, that sort of thing. This is what we're going to do for everyone. And you can set up standard systems that are really rote of, well, they haven't gotten their mammogram in 3 years, they need a mammogram. They haven't gotten their flu shot yet this year, they need a flu shot. There's not medical thinking that goes along with that a lot. You have to review that information before the patient actually, you have to sign off on all that stuff anyways. But you don't actually have to use your brain to sit there and think about it every office visit as the patient's there in front of you. Do they need a mammogram? Do they need a colonoscopy? I don't know. It takes a lot of time from your office visit and makes it really inefficient. So if you risk stratify folks, they have, on this chart, they have 6 different levels of risk stratification. I don't know that there's 6. I think there's actually, you could do it however you want. I think there's probably 4. In my clinic, we've done this for our patients, or we're doing this for our patients. We have 3 different levels: low, medium, high. So you could do it however you want. There's pediatric clinics that are using, 4 levels. But that thought process of actually going through your patients, which is hard work but really valuable, helps again to target your resources so you're not running willy-nilly trying to throw things at different people and not being coordinated in your thinking. And it's also not just your thinking then if you can get that information in a place that other people can access it and think about how do you do that. So I think this is really important when you think about that highest level of complex care coordination, that you're trying to offer really a lot of services or really pay attention to those folks a lot and wrap that care around them. Again, you need to think about how are we going to do that, and then how are we going to do that in an organized way. And then, yeah?
I find that patients move in and out of those last 2 categories.
Yes, right. So it's not static, right?
Right.
So you start out and you say this is where they are right now, and then you are assessing, and those higher risk folks you're assessing, are they really high risk and we need to again have a bunch of resources wrapped around them, or are they sort of in the middle, or again where they used to be really well controlled diabetic and suddenly they came in and their hemoglobin A1C is 11 and they have a foot infection and you're like, what happened? And they stop taking their meds or things like that. And that's why you can't forget about those folks. Is it doing it again? I don't know how to turn that off. So that's, that is important to think about. Again, it's not static. You're judging this at a point in time. Folks move, and so that's a process of thinking about, okay, how often am I going to look at that? Am I going to make that sort of a routine thing where I'm going to look at my high and low risk, high and medium risk patients potentially and kind of reassess that on some regular basis, or am I just going to do that sort of as I'm dealing with the situation? But also, again, concretely say, all right, this person is no longer a medium risk patient. I'm actually going to, they're a high risk patient now because they just went in the hospital and yeah.
Are there any evidence-based studies that actually give us specific guidelines on how to manage these patients for outcomes?
So, good question. Going back to that chart that had this many different domains of care management, we'll go back to this one. This was essentially an analysis of that, of which of these different things actually makes a difference. And it's surprising how little evidence there is that if you just give care coordination across a population, there's really not very good evidence that that makes a difference. And it depends so much on the level of what you call care coordination. So, for example, a lot of folks, there was actually a whole demonstration project called the High Value
PCC.
There you go. Which was a insurance payer-driven thing where they picked who they thought were the high-risk people based on cost and claims data. And then they told clinics, here's your high-risk people. We're going to pay for a nurse or health coach or whatever to work with these people. That was really a failure because the clinics didn't pick the people. The payers picked all the wrong people because it was based on old claims data, and those people were no longer the high-risk people. People don't have a linear health path. They have health crises and then get better, and then have health crises and then get better. And so the folks who are closest to the patients in the clinics actually knew. They looked at the list, they're like, these are all the wrong people. This was a woman who had a hip replacement last year. She's fine now. You know, and they had no power to actually change who they care coordinated. But the mechanism of care coordination was essentially phone calls. So you had folks who, you know, on the clinic level, you had patients who were not necessarily the right patients, and you had really a minimum interaction of an isolated care manager, not necessarily in the clinic, depending on the situation, who didn't know the patient, called them, and got to know them over time maybe, but that was a really minimal care coordination. That actually had some minimal cost savings, but when you think about the potential, if it had been done differently, you know, the results, again, were, especially when I talked to folks who worked in the clinics on this, it was you know, didn't go very well. Yeah, you have a...
We're working with our CCO to try to do some prospective identification of super users or hotspotters. And our CCO is promoting using something called a TrueVent score, which is prospective condition-based. What's the evidence for that?
A TrueVent score, I've not heard of that.
It's some sort of a proprietary analysis software. It's an insurance company, actuary.
Yeah. I would say, in general, the further you move away from the patient, the less accurate your information is, and the less able to predict outcomes you are. So I don't care what kind of computer program it is, it can do some good. It probably is pretty good. Again, kind of that first pass of who's higher risk, who's lower risk. You can do that a variety of ways. I don't think you need a proprietary program to do that. But it's that second pass, that clinical pass, the folks on the ground who know the patients say, again, of these people, well, these people, yeah, that's pretty good, but there's all these people they didn't hit that I know they may not, again, be in and out of the hospital today, but last year or 2 years ago they were, and they live in this horrible psychosocial situation, domestic violence, they're totally at high risk, and I know that it doesn't come out in a coding system or a way to, you know, unless you asked the right questions and actually interviewed the patient about what their situation was, which is what we do. So I would just say, in general, those things are really great as a first pass. They should not be relied upon as the end-all, be-all, give you the right answer.
Because I talked to Pranav Kathari some about HVPCC project, and he actually claimed the clinicians don't do a good job picking out their high users. Then again, he
high utilizers, meaning the folks that end up costing the most money, or the people who are at highest risk of health problems, and those are not necessarily the same people.
I completely agree with that, and I've been looking at this, and I don't know that there's necessarily great evidence, but I don't think that the TrueVent score actually, I think it's more of a who is going to cost the payer more money in terms of hospitalization, and not necessarily who is going to have the worst health outcome.
Right.
Right. I don't think that it's primary care sensitive is what I'm trying to say. I think it's more of a once they are actually in the hospital.
Right. And again, not to say that it's not a valuable tool to use in this thinking, but it absolutely, I don't think you can rely on those tools to tell you the actual list of the folks that are really high risk. It's, you guys know the people, the patients. Your team knows the patients. Again, you find out things that aren't able to be pulled out in a medical record field very well that allow you to think about this. Glenn Rodriguez, who was president a couple of years ago, talks about a study that was done in the late 90s looking at what was the best predictor of mortality over the next year. You know, it was a blood pressure, renal, you know, measures, hospitalization, what was it? It was actually whether or not the PCP thought that the patient was likely to die in the next year was the best predictor of mortality. Which again, I thought that was really revealing, right? We know these folks, and the further you move away, just the less accurate the information is. I think that's like anything. You know, you're looking at when we look at a different galaxy through the telescope, we're making all these assumptions about what it's like. If we were up close, we'd be thinking a lot differently. So things like that. So I just wanted to mention too, this method of risk stratification is actually part of who's doing this comprehensive primary care initiative in their clinics, CPCI. We got a couple. So that is The Comprehensive Primary Care Initiative is a multi-payer initiative trying to pay for primary care differently and reward some of the things that have not been paid for historically. There are certain milestones or benchmarks that the clinics have to meet during this 4-year process. One of them is risk stratifying their patients. So again, thinking about patients differently. Actually, these slides are going to be available after the talk. Everything that is blue and underlined is a hyperlink. So, so this just gets you to a little bit more information about the Comprehensive Primary Care Initiative, what's going on, what the thinking is around that. But that's where this comes from. And again, this is a model that's, this Comprehensive Primary Care Initiative is happening in 7 different markets around the country. If that is successful, then that probably will spread, at least through Medicare, if not the private insurers. So when you think about how to organize this information, if you've said, okay, here's our high-risk patients, we risk stratified folks, we thought about this, we want to do care management, we want to make it robust for the people who really need it, and not worry so much about the folks that don't need it, but put all that great information that's in our brain in a place that other people can use it, including all the folks in our clinic and our team, and the patient as well. That's really where care plan comes in. So the care plan really, there is some decent evidence, not real strong, but decent evidence that care plans have real good benefits for pediatric populations, adult populations, for all these different issues. I think we've seen, when we think about the words care plan, sometimes when I first started talking about it, I thought mostly like palliative care planning, mental health care planning, we do a lot of care planning with that. Folks, again, like who are frequent flyers in the ER and some care plan about we're not going to give them narcotics or things like that. That's the way I was initially thinking about care plans. But this is really something different. This is something about, again, putting the information about sort of risk, medical issues, or summary, what I would like the patient to be doing, what are my goals for the patient, and then really critical to making this a valuable tool is engaging the patient to actually set their own goals, to try and empower them to do some things and improve their outcomes, and then figuring out how to use this care plan in a way that is actually effective, and it's a good tool, and it's a living document that your team uses, that you use, and that it's not just something that sits in the EHR somewhere, if you find a place for it, or sits in a piece of paper and nobody ever looks at it again. So you put a lot of work into making this care plan and then nobody looks at it. So you got to really think about involving your team and how are you going to use it. Thank you. Good thing I have an assistant. I'll just talk really briefly, and then maybe this is the documentation part of my talk. For the Patient-Centered Primary Care Home Program, many of you may know there is some payment through Medicaid that goes along with that, or it can go along with that. In order to get payment through this program, you actually have to make care plans for the folks that you get paid for. These are folks with more than 2 chronic illnesses or 1 serious mental health illness. So many of these folks, just by, again, their diagnoses, are the higher risk patients. The guidelines that made up this program were part of the Affordable Care Act, and we didn't have a lot of say in sort of how that structure was, but generally those chronic illnesses, serious mental health illnesses, put those folks at higher risk. And so a care plan makes some sense. The Affordable Care Act and the structure of this program says that the care plan has to include these things. So it has to include self-management, preventive chronic illness goals, action plans for exacerbation of chronic illnesses, and end-of-life plans, if that's appropriate. So those things are spelled out. And that care plan, if you do get paid, has to be done within 6 months of when you actually submit the list to the state to get paid.
Which is a lot of fun, by the way. I mean, you kind of...
Well, so we're going to talk about it. That's what we're going to spend most of our time talking about. And some of these slides I've taken, I've sort of adapted this talk from a talk that the Patient-Centered Primary Care Institute gave, a webinar that I and others gave back in January, and that's on the website. You'll see the link at the end of the talk. And it was internal medicine folks, me from family practice, pediatricians who all got together to talk about how we do this care planning. And actually the pediatricians have, they were the initial folks who developed the patient-centered medical home model, and they've done a lot of work around care planning and spreading what works so it isn't such a hard process. Still, a laborious process, but so that it really is effective. So I'm using some of their slides, and one of the things that we've come up against, or again, kind of in the culture changes, some of us know when we think about care planning, again, that some of us know about like asthma action plans would be the thing that I think of most when I think about, a plan for care for somebody who has an illness. Asthma action plan is something. So how is that not a patient-centered care plan? So again, an action plan is completed by me. I say, if you are short of breath, use your albuterol 2 times every 20 minutes. If you use it more than 3 times, call me, that's my plan for them. It's a unidirectional communication. A shared care plan is written by me and the patient, okay? An action plan, again, has directions. You're going to do this. A care plan has patient-centered elements where, again, you're engaging the patient around what are your goals, what are your barriers, and then really the other biggest difference is that really that shared care plan is emphasizing the patient's control of their own health. An asthma action plan is kind of like that, saying, hey, you can take medicine to make yourself feel better, but it's really different to say, how do you control your asthma better in general, as opposed to what do you do when you're short of breath? Those are really different things. These are examples, again, from the Oregon Pediatric Improvement Project, talking about how you engage patients, and that's one of the hardest things, actually, is engaging patients. I never got training in motivational interviewing or how to help patients set goals or things like that. It's sort of assumed that we know some of that stuff. I mean, maybe I got that in residency, I don't think so, but I don't remember that. But the language that you use is really important. So these are just some examples of the things that the pediatricians are using with families and their patients to describe how, when you're writing this up and describe what they're thinking is using these sorts of things as opposed to, again, Joe says he learns best like this. It's I statements, because ideally you're going to actually share, again, you're writing this together with the patient, you're going to share that information with the patient, and if it's you will do this, again, it's a directional thing, and you want them to own that. So the language can be important. So again, just kind of, you guys, many of you know what an asthma action plan is. So again, just, if you have an exacerbation, here's what you do. And that's a different thing than a patient-centered care plan. So how could you make that asthma action plan, again, exacerbation of an illness, how do you make that? You could potentially make that into a shared care plan so that it's not necessarily, if you've already done an asthma action plan for somebody, let's say, maybe you haven't, but if you have, it's not a huge step to then move that into more of a whole person care plan. And really you have to assess patient goals, potential barriers to treatment, and help them problem solve around why, what they need to do. So if they live in a house where they're allergic to dust mites and they never vacuum, well, that might be a really important thing to address, but we usually don't get to that conversation. We're usually focused more on, again, are you using your flow vent, and how much are you using your albuterol, and what's your peak flow? And their focus is really different, so we have to take that into account. Self-management support, again, like I mentioned, I did not get any formal training in self-management support. I don't think most of us got formal training in self-management support. But this is just the 5 A's of self-management support that I thought I'd put in there to assess patient beliefs and their readiness to change, advise patients, agree on certain collaborative goals, assist the patients with problem solving and identifying barriers and strategies to overcome those barriers, and then arranging a specific follow-up plan. So again, if you're care coordinating, this is not something that happens one time and you're done. It's what happens after this is done. This is the starting of a conversation, right?
So Evan, who do you think should be doing this?
Great, we're going to talk about that next. This is just, again, kind of goal setting guide. This is a little form that anybody could, this was made up, and anybody could use this sort of thing, assessing what patients want to do, how motivated they are to do that, how likely they think they are to do that, what their barriers are, is sort of this form. But so to Rick's point, really key is again, just working collaboratively with patients' families, identifying goals that are, use this acronym SMART, which is really a quality improvement acronym. It's kind of like PDSA cycle, plan, do, study, act. This is specific goals, choosing goals that are specific, so not like, I want to lose weight. That's not a specific goal. I want to lose 10 pounds is a specific goal. In how much time, so something that is measurable, so I'm going to do this, or I'm going to cut down on my soda. I'm drinking 6 cans of soda a day today. By next week, I'm going to have to drink 3 cans of soda a day, and by the next time I see you in 3 weeks, I'm going to be down to 1 can of soda a day. Those are specific goals that are measurable for the patient, so they can tell whether or not they're progressing, and you can tell whether or not they're progressing. That they're actionable, again, like if they say, well, I really want to get in shape, and so I'm going to run a marathon, or I'm going to do, I'm going to exercise every day for 45 minutes, and you know they can't do that. You have to help them set realistic goals that are actionable, that they can do. That's both realistic and actionable. And then again, the timely piece of having a goal time, helping them set a time frame for that, so again, they can measure how they're doing, you can measure how they're doing. Starting small and building on success, like anything like our quality improvement work, like any sort of culture change or behavior change, you can't again say, I'm going to change my world, and do everything different. You actually have to pick small things, have some success, build on that success so that you feel good about it, is the way it's going to work the best. Finding that really regular feedback or touches, so sort of on the more intensive side of the complex care coordination piece. And then using rewards is really important as well, right? And the patient can set the reward. So again, if they feel like their reward for not smoking is having a soda, and you can negotiate with them that they're gonna, if they go 4 hours without a cigarette, that they can have a soda. You can negotiate whatever you want with the patients. They're gonna identify what their motivators are. You have to have a negotiation and come to an agreement like any sort of treatment plan. And then, to Rick's point, really goal-setting discussions and follow-up are perhaps best done by what I have as allied health staff, so medical assistants, nurses, community health workers, folks that, a lot of this work, again, is like motivational interviewing, goal setting, things like that, that doesn't have to be done by us. In fact, we haven't necessarily been trained to do that very effectively. And then essentially start with something and then change it and try and improve it over time. So we're doing this again. If I only knew how to turn that off. So really critical and kind of getting to the EHR question, the process is really going to be different in all your practices. So first, again, you have to assess what's the health risks of your population, what are the issues that of your clinic population that matter and that you actually want to address in these ways. So it's going to be really different. The EHR capabilities of each different EHR are extremely variable, and again, some are better than others in terms of being able to have a place to manage this, and some just don't have a place to manage it. And so sometimes you just have to pick a place to put something and create what you want in that space. So some clinics, and I'll get to this, but some clinics are doing, even though they have really robust EHRs, they're developing what they want in a care plan on a piece of paper, old-fashioned way, and then figuring out after they have that developed and it seems to be something that's going to work for them and their staff, then they'll figure out how to put that in the EHR. I don't know that there's a right answer. It depends on your EHR and again the functionality of that and how your organization works and all of that. But it is going to be different places. This second one is really probably the most important point, and that is involving diverse staff members in the development and the discussion of how the care plan will be used. Again, the last thing you want is to put a ton of work into developing really robust care plans, shared goals, and all this stuff, and then have it sit somewhere that nobody ever uses again. If it's put in a place or folks are involved in that discussion about how can I do that? How am I going to be involved? How are we going to follow up on that? And again, not just you, but your medical assistants, your nurses, your other folks in your clinic, that document or that thing is going to become a living tool that actually is helpful. But that discussion has to be really important. And then really, again, this other piece of you know, we all struggled. How do we engage patients? How do we involve patients in their care? This is a great place to do it. If you're developing these things, is to go ahead and involve patients, families in looking at these things and say, so what do you think of this? We're going to use this. You know, there's certain patients, like the folks that you might think, you know, that are pretty together, but have strong opinions, and you value their opinions. You can ask them those things. You can think about doing that on a more comprehensive level in your clinic if you want to, or if you have a patient advisory council or something like that at your clinic, you can do it on a more robust way. But having patients and families, and then also even external folks review these ideas, what you're thinking about, is really valuable. Just like any idea, if you all sit in a room, we think of a really good idea, when we get outside the room and talk to somebody else, they'll go, well, what about this? And you're, I've never thought of that. So actually having somebody external look at it who was not involved in the process is good as well. Yes?
It strikes me that this is a lot of work,
Yeah.
and that it actually might be made easier by doing it in groups.
Uh-huh. Yes.
You know, with the care manager,
Uh-huh.
doing a group visit or something with a bunch of diabetics or asthma patients.
Yeah, so group visits in general are a great way to set goals, and again, have that kind of peer learning when somebody hears somebody else set a goal, they go, oh yeah, I might be able to do that. And so there's no set structure that you have to do this in. Again, you're just trying to figure out a great way to engage patients, have them set goals, have them identify barriers, establish all this information in one place. You have to think about if they're going to be willing to share that information, you know, honestly during groups, but my experience in group visits is usually people share much more than I ever thought they would. Yeah.
I think there's at least an element of this that has to be done by a licensed person, is that not correct?
It has to be reviewed and signed off by a licensed person.
Okay.
It does not have to be written or...
I mean, that could be like, you know, your RN care coordinator or whatever, but...
Exactly, but the other piece is really, and the reason you know, that is important in terms of, this is for the payment, for the...
Right, for the APM, because we said we had
Yes.
this like backlog of 2,000 people that we had to like, you know, get these care plans done right away
Yes.
on, and so we were trying to make this system to do that.
Yes.
So, you know.
Yeah, so again, anybody can develop the care plan with the patient, fill the care plan out with the patient. Because, and I'll show you some examples, but because most of the care plans actually have the healthcare team or physician goals in there, you know, usually you're going to have against probably the physician or a nurse or somebody, a licensed professional, again, think about what are those medical goals. Those are not required to be in the care plan per se, but often, usually they are. And then, again, it would make sense that the PCP would want to look at that care plan and have some sense of what's in that care plan, but they don't have to be the ones who develop it. Just somebody licensed has to be involved in that and essentially sign off and say, yeah, that works. Does that make sense? So these are actually some care plans. You can't see very well, but these are actually some examples of care plans. And again, varies widely on what's involved. This was one example of a clinic that had an EHR that they didn't feel like was functional to do this work, and so they actually developed a piece of paper care plan, and then are now figuring out a way essentially to get this into their EHR using, you know, they're contracting out, figuring out how they can get something on top of their EHR to be able to do this. But they went back to the old-fashioned thing, and they had, you know, a medical diagnosis and specialists, and have they been to the emergency room or missed appointments, well child exam, immunizations up to date, what are their, again, you can't really read this, but this is goals set in collaboration with patient and family. What are their chronic care goals, preventive care goals, and then follow-up, to do. Care coordinator or team, what are you going to do? Provider, what are you going to do? Child or parent or family, what are you going to do? So this is an example of a care plan. It's a pretty robust care plan, relatively, if you fill all that out and really engage
Is
patients
it
around.
realistic you could actually keep track of when they're gonna see their specialist next? That seems like that's ridiculous.
Well, exactly. So this piece of, yeah, so if it's a piece of paper and you're trying to write down when the next visit with the specialist is, that gets us back into the paper chart, thinking about how do we track that kind of thing. If you're going to include something like specialist and next visit with the specialist, you know, it would make sense to make that part of the electronic document. In here, they included that. I think it's important to actually have the list or the the medical people, the specialists and primary care who are involved in care for the patient, actually on the care plan, I don't know that it's that important to say your next visit is this. It may depend on the patient. You may actually want to put that in there. Again, if they have 6 different specialists and you're trying to figure out, well, when are they actually going to see these people, make sure they actually follow through with all those folks and stuff, you may want to incorporate that. That could be almost in, you could almost put that in care coordination and then to do things to follow up on. So again, this is just an example of what one pediatric practice used. I'm going to now show you an example of what I use, which again, this is actually the first care plan that my team did, and to get to process. So because the care plans have to be done for payment, I work in a large organization, and the large organization said, wow, we need to get all these care plans done, and we need to get them done really quick. So we all sat down in a meeting with this directive, and written up on the board was, what are we going to do for the care plans, and how are we going to do it, and by what time? And I raised my hand, because I'm a troublemaker, and I said, what about the why we're doing this? And that was the most important part. Why are we doing this? Not what do we have to do, by when, how. Why are we doing this? To improve patient care, to improve communication, to put all that good information that we all have in our brains someplace that can work for everybody to use, to engage the patient around setting goals. It can serve a lot of different purposes. When I talked about that, the medical assistants on the team, the front desk people were like, oh, yeah, like there's this patient who is, he has schizophrenia, he goes off his meds all the time, and he'll just call up and say, Dr. So-and-so just cut off my arm, and da-da-da-da. And when I talk to him, I know, oh, okay, he's off his meds, here's what we need to do, get him to the, but if anybody else picks up the phone, they're totally freaked out, and have no idea what to do. Wouldn't it be great if we had some way to describe that, so that people could see what's happening? And another person said, well, this goal-setting thing, a medical assistant said, this goal-setting thing, does the doctor need to do that, or can I just do that? And I was like, oh, bless you. And she said, but it seems like we should get some training in how to do that first. Yes, excellent. So we said, okay, we're going to we have a behaviorist and psychologist in our clinic, and so we had our behaviorists actually teach the front desk and the MAs, but everybody, about motivational interviewing, setting goals, things like that. And so this was our first attempt to set up a care plan. It's not perfect because it was our first attempt. It's never going to be perfect. And that's actually a learning point too, is not spending a gazillion hours on trying to create the perfect care plan process and then go, boom, we're going to implement it and everybody's excited. No, you actually have to work out some of these things like who does it, when do you do it, how do you do it, by just doing it. So you come up with a good idea that you've discussed, think about training and who's going to do these roles, and then try it and see what happens, and you're going to have to change some of these things. But thank you. So this is a gentleman, so again, we have on here, we have that he's high risk. This is my medical assistant. She was the one who actually initially wrote this. Even though my name is not in here on this part, I did look at it. And so this gentleman, he has agoraphobia, anxiety, obesity. He's like basically in his house, can't come out. He comes out. He's improved a little bit. Diagnosed with diabetes, really obese, and then he was admitted in the hospital with what seemed like asthma exacerbation, but he didn't really get that much better. So we were a little bit worried about him, right? He actually went in the ER a couple times after the hospitalization. So he's part of our team, this Team C, my name, personal support team, and then patient's goals. So he wants to walk 8 blocks every day. He came up with 8 blocks. He says, that's about what I think I can do. Great, 8 blocks, okay. And he said, well, but if I'm not short of breath and I'm feeling good, can I walk further? Is that a problem, or is that gonna hurt me? No, hey, go for it. So we put that in there. He's like, yeah, I don't really eat vegetables at all. And so again, we said, well, let's think about that. So let's put in there. Okay, so you actually want to eat vegetables and eat healthier. You want, let's put it in a way you can understand. It's like, what vegetables? I don't know. So we just said plants. Anything that's a plant, go ahead and eat that. That's good. He was drinking a ton of soda. He's drinking a ton of soda, I think like 6 or 8 a day or whatever. And he's like, you know what? I'm trying to not drink the soda, but I really like the soda, and so I'm trying diet, but I don't know if I really like it. But I think I could try and make that a goal. And so we put that. We tried to help him with self-management tools, get him an appointment with behaviorists. He didn't want to do that. We didn't have anything else in here we could think about. There's probably other things that we could have given him to do, to work on that are self-management tools. Barriers to goals. Again, this was really our barrier. This was not his barrier. This was us saying he has agoraphobia and anxiety. That he didn't say those words. So this was not really that ideal in terms of, ideally you'd like to get him to say, what do you think would keep you from walking 8 blocks a day?
So that would look like outside is scary.
Yes, outside is scary. I'm worried that I'll get, so short of breath that I won't make it home. I don't really like vegetables, and so I don't know how I'm going to eat those. Or I can't afford vegetables, let's say. They're too expensive. Or again, there's my family. All they do is buy a bunch of soda, and so there's a bunch of soda in the house. So I'm worried if it's there, I'm gonna drink it. Those identified barriers. So we didn't necessarily do this ideally. We said what we thought the barrier was. And then these are my goals. Ensure pulmonary workup is done, improve his diet and exercise, and then try and figure out how to manage the psychiatric issues. Again, those are not his goals. And then he had an action plan in the chart for asthma. What do you do if there's an exacerbation? So this meets the needs of the state, payment plan in terms of care planning, but it also provides folks kind of a little summary of what his issues are, an idea of who's working with him, what our goals are, what his goals are. Yeah.
So for your team goals, did you come up with those with the patient too? Like say, well, what are the things that I could be helpful to you? What are things that you feel like I could do? Or do you give, like say, these are things I could do? Do you think, or are those things you guys came up with later?
These were things that we came up with, talked about him with it, and showed him this care plan. And actually, ideally, you'd probably print this care plan out and hand it to him, right? And some people actually have folks sign their care plans, and the doctor signs, and the patient signs as almost like a contract, right? Which can be very valuable. But yeah, we came up with these goals and said, hey, we're not exactly sure what's going on with your lungs. We really want you to go to lung doctor. He's like, I really don't like going anywhere except for here because I'm scared. And we're like, no, but it's really important. And so that was our goal. These team goals were our team, my team, medical team goals. Yeah.
It seems like after you've dealt with his asthma, his mental health problems, and his diabetes in a office note procedure, the didactic of going back and forth question and answers with him, this becomes extending that time in the office a lot.
So if you do it, you're right. It might extend the patient's time that they need to take in the office to set up the care plan initially, but when you touch that care plan, so we've seen him back, and so Linda will say, hey, how much are you walking? And he'll tell us. Or how many sodas are you drinking? And so she actually uses that in the rooming process. It's really quick. She'll, as part of the rooming process, update the care plan if he has new goals or, again, saying he's meeting those goals. But it's actually a really quick process. If I were doing that, yeah, that would take, for me to set up this care plan is a whole appointment, right? That's a 20-minute appointment of going through goal setting and things like that. But having my medical assistant go in, trying to set some goals with the patient and barriers, and then me coming in and sort of confirming those things and say, hey, Linda said you want to stop drinking soda. That's awesome. Is that, yeah, he's like, oh yeah, I'm really excited about trying that or whatever. So if the other folks on your team are primarily involved in helping set up that care plan, that's ideal, but it does take time. It's definitely work, and that's why I really want to push on the point of trying to make sure that this is not a one-time exercise, that you put a lot of work into this. You put a lot of information down, you spend time, and then it just sits there. So you want to really think about, okay, if you're going to do this, how are you going to use this? How is this valuable? And again, what we find some through evidence and definitely through my personal experience is it is valuable because it puts that information again in a place that other people besides me can use it, including the patient, other people on my care team, and it engages the patient around setting goals that I don't think we do generally very well in in medical care. We set our own goals and we tell the patient, tend to do, tell the patient what we want them to do. We've never been very good at engaging patients in setting their own goals. That's just a hole in our education. And we have other folks on our team in the community, again, folks, the medical assistants, folks, if you get the training, it could be us, but I think most of us are pretty busy. If you give other folks the training, they can do this work. The training is important though. Yeah.
I think this is all great and we need to do it. It just sets up the next level, which is, what about the cardiologist and the nephrologist that's seeing this patient? And when they go to the ED or urgent care, has anybody ever looked at this?
Very good. So that's a great point. So depends on how you communicate, right? But so to pick a system, you work in a big system. So Legacy had this conversation. They said a bunch of our clinics need to do care plans. The ER also already has care plans for people who are frequent flyers and we don't want to give narcotics to. But we have actually 6 different ERs and they all use different care plans. So they actually use this as a catalyst to sit down and talk about, okay, if we're going to do this and put resources into it, how is it going to be used? It has to be in a place that everybody knows where it is. The ER has to be able to look at it. When they're in the hospital, they have to be able to look at it, and they actually have to be not the requirement, but the expectation is that they will look at it. So that actually catalyzed that conversation about, because we have to do this and because this is important and gives good care, let's have that conversation with all those people who might look at it to talk about how we're going to use it, how it's going to be a living document. It's not just going to sit somewhere in the EHR.
That was Prod.
No, that was Legacy.
Legacy.
Yeah.
Let's go back to how you get reimbursed for this time, the resources, because really the way we make money is by spending time.
Yes.
And is this, if you're in this system, you're doing this and you're getting paid extra for this, so however you get it done, it's more of a capitation thing, and you're going to get reimbursed X amount per patient per, or is this, do you schedule time with your clinical assistant, to do it, or how do you try and make this be an economic thing?
Great question, and really important. So with the Medicaid payments for patient-centered primary care homes that are existing right now, depending on your tier level, you do get paid a per member per month payment. So if you're a tier 3, you get $24 per member per month for everybody that you're saying that is qualified and that you actually create a care plan for. So it's $288 a year, which is, I think, probably what, a 1.5, is it almost? So it's the equivalent of that. So if you think about that, if you think $288, what is it, 1.4? What is it?
Well, you get
1.4.
You don't get too much more for doing more.
Right, but think about it. So let's say it's whatever it is. How did that happen? I guess that's perfect timing. No, my last slide is just a thank you slide. So if you think about for the Medicaid piece, only the Medicaid piece right now, this is required to get paid within 6 months, and you get some significant reimbursement for doing that work, essentially, and that's the reason that the program was actually set up to try and reimburse services that are not currently reimbursed. So that if, just for Medicaid patients that are qualified, you would get reimbursed for this. In the Comprehensive Primary Care Initiative, the folks that are participating in that, they are getting also per member per month payment from all of the payers. It has to be usually more than 60% of their patients have to be in that, from all of the payers per member per month payment to do this work as well. Outside of that, there is not reimbursement for this. It's about trying to get better patient care, which is not the way to keep the doors open necessarily. And so what we're working on with the program and in the state generally is really, again, how do we spread the reimbursement piece and change our reimbursements with it. This kind of work and a lot of other work that we do is actually reimbursed, so we can do the good work and keep the doors open and have the staff to do it. Right?
Actually, I think the long-term view at the state level, and you know this is outside, that part of pay for performance, which is in addition to the capitation,
Right.
This would be part of, and then if, when they get some sort of gain share, reduction of emergency room utilization, hospital utilization, so on and so forth, will translate to getting paid more, or at least getting paid the same.
Getting paid.
Yeah, getting paid. And it's, yeah, I mean, we're in this tricky place of this in-between place, of course, that all of us recognize that, we're talking about doing these things and really the other talks around primary care homeness and the things to do. And many of those give cost benefits or health outcome benefits, the cost benefits to the payers and the health outcome benefits to our patients. But wrapping that around so it's actually, again, cost effective for us to do that is a piece that we only have parts of in place right now.